All right.
Okay. So if we're ready, we'll go ahead. Are you hearing me okay?
Yes.
All right, and you don't need to see me, but you do need to see the slides. These are our global learning objectives, and our specific learning objectives for today are to review the most common types of unexpected drug screening results in urine drug toxicology, list some strategies for managing unexpected results, reflect on our own approach, practices, and our own serenity and comfort when we're managing unexpected results, and then to consider some future directions, which I think Dr. Ballister has already made a comment about. Just a kind of preface is that most of the things that you're going to hear in this presentation are really a kind of category C evidence. They're recommendations that are based on expert opinion, which means, you know, people who have been doing it longer and more, but not necessarily with the kind of evidence that we like to have, which are randomized controlled trials and other evidence that guides us in ways that aren't just dependent on our own experience. So this is an area where there are many questions to ask, including, is our expert guidance helpful? Is it harmful in some ways to patients? And how can we get better evidence that would guide our use of urine drug screening for our patients with opioid use disorder? So next slide. What we hope for in a urine drug test, you'll see UDT for urine drug test and the UDS in this presentation, urine drug screen. That's that initial test that most of us are doing as when we're testing urine. We're doing a broad screen that is sensitive and may not be specific. When we get that test, what we're hoping is that, first of all, the testing material will be reasonable. The temperature is appropriate. The creatinine that we find in the urine is what you'd expect to find in human urine. There's a backup test, the confirmation test. This is one that's going to be much more specific than our screening test, and that helps us to find false positives. We expect for a buprenorphine test that both buprenorphine and norbuprenorphine are present, and buprenorphine glucuronide and norbuprenorphine glucuronide that are all metabolites of buprenorphine, and that we hope that other substances tested will be absent, or that the ones that are present are ones that we expect and ones that we have allowed in this patient's treatment plan. Next slide. But it's not always that way. And in fact, I think we've really evolved in this field to think that, that unexpected results are what we should expect. As they say in Al-Anon, expectations are resentments waiting to happen. And if we expect that once a patient enters buprenorphine treatment, they are going to have a perfect record of negative urine drug screens from initiation onwards, and they're never going to have an unexpected substance pop up, well, we know that that's not an evidence-based expectation. In fact, we should expect positive tests of different kinds because of the natural history of substance use disorder. Then we also know from observational research that that patients who may be doing fairly well in treatment regarding their opioid use disorder may continue to have other substances show up on their urine drug screen. And then that's an issue for us to decide what's helpful for that patient and what's harmful when we see those unexpected results. Sui's study is looking at patients who use amphetamines who are retained in buprenorphine treatment, and the outcome is that a whole lot of those patients will still have amphetamines showing up intermittently, and what we decide to do about that, we don't have really good evidence-based recommendations, just those ones that seem to make sense, you know, based on our clinical experience and reasoning. We do know from other research that when patients are showing up with illicit positive tests, that they're more likely to get re-exposure to an opioid. They're not necessarily more opioid to have a relapse of their opioid use disorder. So, you know, again, just another issue in evolution. Here's McDermott's study that I often cite for different reasons. And you know, if we wrap our mind around it, it's telling us that when a person starts buprenorphine treatment in this study, if at 2 weeks into their treatment, they were abstaining, that about 2/3 of them, 3/4, were likely to be still abstinent from opioids at 12 weeks, and in 2 out of the 3 preceding weeks, meaning about 30% of people are not going to be abstinent from opioids. And that in this study, early opioid use, a person that never stopped using their illicit opioid, despite starting and getting to an adequate dose of buprenorphine, predicted ongoing opioid use 12 weeks into treatment. But it didn't work the other way. Early abstinence from an opioid didn't predict ongoing abstinence 12 weeks into treatment. This just, to me, says that we ought to expect that the road will be kind of rocky when we're starting buprenorphine treatment with a patient, and that patient that gets absolutely negative drug screens for opioids and other substances may be more of a rarity than an expectation. And category C from me, from being at the methadone clinic for a long time, it often takes patients a year to 2 years to decide what are they going to do with their other substances, and to really kind of get into the pattern and embrace the benefits and also the things they would need to do to be sober. Here's a study that just tells us not to be disappointed if we're seeing positive drug screens for different things, opioids and other drugs, initially in that treatment, and to try to stick with it and stick with the patient. Next slide. So, you know, some things for us to have to think about when there's an unexpected result. You know, one is, unfortunately, we can't know the extent of the truthfulness of what the patient is telling us. We can think if we show up, a positive test shows up, that we ought to explore it with some non-judgmental, open-ended questions, and looking with the patient for other plausible explanations for that unexpected positive test, and considering diversion, co-substance use disorder, and judgment lapses in that list. You know, that's that slip that that people will talk about in AA. That's a kind of part of that natural history of substance use disorder. Thinking, you know, how could that substance have gotten in there? Asking the patient, what can you tell me about that? What might have happened, especially if they seem genuinely surprised to see that positive test. And then we'll go on to consider additional steps that might be helpful for that patient's accountability. Increased frequency of visits, shorter prescriptions, more testing for different drugs, testing to confirm that that unexpected positive really is a true positive. This is the time when we might include some more random or observed testing, pill or film counts, testing a different matrix, or referring to that notorious higher level of care, if there's one available, where the patient generally will have more supervision and more psychosocial interventions. Next slide. Why take this neutral, non-judgmental approach when we see those positive screens, especially if we're not really surprised by them and we're thinking the patient, you know, when we're not so much in this frame of mind that we're thinking of substance use disorder as a chronic relapsing disorder, but rather thinking about it as a kind of effort of will, where if the person just has enough willpower, they'll be able to do all the things they need to do to stay sober. No, when I'm in that frame of mind, I will often feel a rush to judgment, thinking that the patient's not serious about being in recovery, or they thought they could get this over on me or something. But really, that's not therapeutic for either them or for us. It just raises our own blood pressure and it doesn't help the patient. If we think, well, let's have a little empathy. What if it were me or my child getting this unexpected drug screen result where they, really weren't expecting for a certain chemical to show up, and there it is. How would we want them to be treated and talked with? How would we want ourselves to have that conversation on the other side? Keeping in mind that we really are healers as treatment providers. We're not police and we're not lawyers or judges, and we're not in a forensic situation. We're in a situation where our drug screen is supposed to help us make a treatment plan, not decide if the patient needs to be punished or not. Urine drug screening is one piece of clinical evidence in a bigger picture, and those results should allow us to ally with the patient to manage the substance use disorder. Here are some Category C useful statements from Chris Delastreas, who's on our call here, that I have used many times that help me to feel like I'm an ally with the patient. I trust you. I don't trust your substance use disorder. Your substance use disorder wants to keep you sick, and it's up to you what you decide to do next. Oh, Lane says, these are category A, not C, so we'll talk about that later. A always being better when we can get some evidence. So here we are starting out with our urine drug screen, and to just think about it as a starting point to what we're going to do next, not the capstone that's going to provide the judgment that we would apply to a patient. It's just a kind of a starting point. If we think about how we react and manage an unexpected drug screen, I think for me, I would go through these 4 steps. I'd have my expectations, and I may be surprised by seeing that positive test if it doesn't adhere to what my expectations were. And then I have to think if my expectations were reasonable. Then I need to interpret it, which is to understand what is that test telling me, and what are the limits what are the limits to the tests that we have in terms of how certain we can be that they are true positives. True positive test has a meaning. So a true positive benzodiazepine for my patient that I know has a benzodiazepine prescribed by their psychiatrist, they really need it, they benefit from it, they functionally improved, is different from a true positive benzodiazepine where the patient has no prescription and I don't know what it's doing there. I just know they're not doing very well in recovery and something seems to be wrong. I'm going to ascribe different meanings to those 2 positive tests. And I'm mostly going to be thinking, is it safe or unsafe to continue medication for opioid use disorder? I think we used to think differently about this. We used to think, well, is the patient meeting my expectations? Are they worthy to continue? Or are they not taking it seriously and I'll kick them out of treatment? Now we know that dismissing people from treatment for having substance use disorder and having it play out in their urine drug screen is often not a therapeutic thing for them. It's not helpful for them. And I'm really thinking, unless something shows up that makes me think it's unsafe for them to continue and that I need to link them to some different thought, or they need to go out and think about it for a while, I'm going to be continuing and deciding what to do. The significance is related to, what do I do next? How am I going to work with this positive test, and what needs to happen? Continue or stop treatment? I am going to do my best to continue if I feel that it's safe. What's that positive test doing there? That's that conversation with the patient and potentially intensifying not only resources, but accountability for the patient. Thinking about the big picture when we have that unexpected positive might be looking at Where is the patient in their recovery journey? Are they engaged in recovery activities? Are they going to 12-step meetings or doing the best they can right now anyway? Do they have a sponsor, a phone list, a home group that they can tell you about or show you? Are they working on a step, and which one? How actively are they engaged? Are they attending counseling, IOP? Have they ever had the experience of IOP, or did they just kind of wander in thinking they want treatment and they might benefit from that? Are they taking care of their medical and psychiatric problems so that those aren't interfering with their ability to abstain from substances that they don't want to be using? Are they in a sober living situation, prayer, meditation, exercise, housing, employment, environmental stuff? How's that going for that person? Honesty, openness, and willingness is one of those kind of catchphrases. When the patient can't be honest, despite knowing that we really want to ally with them and to keep them in treatment, that makes it difficult for me to know that things are safe for that patient. So I think that sometimes is the line that tells me that the patient's not going to do well in my treatment program if they're not able to let me know what's going on. I feel like I then can't help them and might be sending my buprenorphine into a situation where they're likely to have some co-sedatives and get into some trouble. But if we set that as a kind of a guideline in our treatment agreement that we want a patient to be honest and open with us, and we're not going to use what they say forensically. We're not in a court of law and judgment. We're here to help them. Then that's the patient meeting us halfway by being willing to tell us what's going on. What follows is a bunch of common scenarios, and we don't need to talk about all of them. I've kind of grouped them up into things where you just think, what's going on here? This is odd. That situation where the number 5, the looks like what we're seeing is diversion. The situations where the patient maybe has decided they want to change their opioid use, but they're not sure about these other substances that they may be using and are showing up as positive. And then that situation, that's this McDermott situation where the patient is using their buprenorphine and you're seeing metabolites, but they still are using some illicit opioids. Number 10 is the one that we should just be aware of, and that should be fairly common for us to see, where we've had an unexpected positive screen for a substance, but the confirmatory test comes back negative, and then we just need to think about how did that screen pick up a positive, become positive when the drug actually wasn't present. So I think we'll flip kind of quickly through these cases. So let's just go ahead here. So this is this thing where the behavior is just not right, or overall the patient doesn't seem to be functioning better, maybe even worse since they've been in treatment, but the urine drug tests that you get back, the urine drug screens are negative. And we'll say not only the screens, but the confirmation tests may show you, well, there's no drugs there's no drugs of abuse to explain this. We could think, and we must always think about the fact that our urine drug screens are pretty limited. There are a lot of drugs that they don't pick up. Is the patient using one of those and having altered behavior because of that? Are there medical causes or psychiatric causes of their behavior and ability to function not being where we expect it is? And can we coordinate care for that? You can see our strategy notes. Again, most of these are kind of category C, derived from tip 63 and the national practice guideline, to say, well, these are things that we can try to get better information about what's going on. So all some things that we can do. And I think if we're thinking about medical or psychiatric causes, depending on where we are in the patient's care, we would want to coordinate care and refer them to get those things assessed and managed. We'll go on to the next slide. Just a reminder of drugs that patients may use and become dependent on, develop a use disorder around, but are not picked up on our usual drug screens. So these are ketamine and fentanyl analogs, synthetic cathinones, that's basalt, that kind of drug, and synthetic cannabinoids, that's K2, and all of that other series of synthetic cannabinoids that are harder to distribute and to use in Ohio than in some other states, but are still around. Dissociatives, and there is apparently a group of novel benzodiazepines that are going to come into use or already are in certain states that aren't detected as a benzodiazepine. Even if we think of clonazepam, you know, we can know that a patient can be using that therapeutically as prescribed and it not necessarily show up as a benzodiazepine. So some of this information is coming from Steck and her group's recent presentation at ASAM 2021, just to kind of acknowledge that there's a lot of stuff that people can use that alters their behavior and their overall ability to function in life that our urine drug screen is not going to see. And next slide. The next situation is the urine drug screen appears to be tampered with. So some things to consider are having a temperature strip attached, thinking about, you know, you don't know until you get the test back what's the creatinine in the urine. Creatinine under 10 may point towards tampering. If we add a urinalysis, we can see that pH, specific gravity, and creatinine are all reasonable for human urine, but that's information that we could not get every time, but I certainly do add randomly just a urinalysis that helps me to check that I'm really getting a kind of a non-diluted urine sample. And we can think about imposing some physical limits that deter tampering. That would be putting some dye in the toilet water, putting the sink outside the room so that the patient doesn't have access into the same room. Oh, Chris is just putting up a message. Are there particular meds that cause false positive for fentanyl? And I'm just going to make a commercial here that I am sending you a nice paper about using urine drug screens in primary care by Nalima Kale. It's 2019, so it's still pretty current, and it has a whole lot of nice accessible tables and charts. It has a nice false positive list, and it has a nice list about how long to expect substances to appear in the urine. So please enjoy that article and use it as for questions like that one, which will also, I think, you know, kind of the group might have some experiences there too. And regionally, whenever you go to ASAM, the national conference, you really have an appreciation that regionally things can be very different too from place to place. So what applies in Colorado may not here. So those strategy notes are that the patient knows from doing their informed consent that you expect them to produce a urine test, that if it appears to be tampered with, they're going to need to discuss that with you and to let you know what's going on. And then from the other end, that having a positive test does not mean that they're going to get kicked out of their treatment, that it's not going to be approached punitively. It's going to be approached as a piece of information about what's going to be the safest and best treatment for them. And sometimes for that patient where the urine doesn't seem like it's a proper sample, just getting a new sample and reminding them of that is something that's helpful. And when tampering is suspected or known, probing the patient's fear of discovery. What prompted that tampering to take place? Once the patient knows that, you know, we're generally going to know if that urine has been tampered with, and we're going to need to discuss it and to use it as a way to continue that person's therapy rather than kick them out. I think they're much less likely to tamper. Here again, you know, there are many, many ways that patients will try to keep ahead of us and have tampering methods. The Whizzinator, you can Google it if you'd like to see it in more graphic detail, but it not only gives you a fake urethra to pass the urine through, but it includes some high quality synthetic urine that can pass through this device and look to an observer like a urine sample is being provided, and will give the same creatinine and pH that human urine would, but it's not. So there's a kind of way that people can try to falsify a sample. Urine luck is a kind of a chemical agent that you can add to urine that will preserve its urinary qualities, but will mask some certain medications and illicit drugs that would be in urine. So there that is. If there are no buprenorphine metabolites and no other drugs of abuse, you could think, well, is this person really in recovery? But the buprenorphine that they're getting isn't showing up in any way. There's not even a shred of metabolites here. Rapid metabolizers generally would have a little bit of norbuprenorphine. If the dose is very, very low, you may find that by the timing of the urine test, you're just not picking things up at the threshold of your test. You could think of this patient who may be using their medications in such a way that it's not going to show up positive. Like my patient who was dividing her 8 milligram strip into 16 pieces and taking them at half-hour intervals. Then we can think about maybe there really is no buprenorphine in that urine at all, and it's just being diverted to test to buy a drug that we don't test for, those novel drugs that were on that previous slide. So some strategy notes, discussion, and thinking with the lab, partnering with the lab to possibly look at setting a lower threshold for detecting those metabolites of buprenorphine. Some labs can do that, and some can't, but something to think about. If you're in a big system, you often will be able to detect buprenorphine at a positive place. Says Dr. Ballister, yes, the confirmatory test should be telling you what's there and what's not there, but it can only be positive if the threshold is low, and most confirmatory tests are different in that they do have a lower threshold for detection. So, that screening test may be negative. The confirmation should show you at least some metabolites, and if there are none, then think of those other scenarios. This is the tampered test. There's a whole lot of buprenorphine. There's probably naloxone, but there are no metabolites. This means the drug did not pass through a liver. It just went directly into the urine. It usually means the person has, in some sort of desperation, tried to fake up their urine to look like they're using the buprenorphine when they haven't been. Explain non-judgmentally, ask about it, then this is, again, one of those examples of the patient not being honest and not being able to trust our doctor-patient relationship. So that would be a patient where I might say, you know, if this keeps happening, I may need to taper, discontinue the buprenorphine, help you to get some different kind of treatment for your safety, because I can't really know what's going on with you if I'm not able to see your legitimate urine sample. Next. So no, but metabolites, other drugs are present. This usually would, you know, kind of point to diversion, and that would be one of those situations where we need to have some more discussion and to clarify with the patient what are their goals being in treatment, and